It feels like we're just swimming in information these days,
Yeah,
right? Like just constantly bombarded.
absolutely. It's hard to know what's actually important.
Exactly. And that's why
Yeah.
we do this deep dive. We try to cut through all that noise, pull out the really key stuff and give you that shortcut to properly understanding a topic.
Hmm.
So today we're diving into HIV/AIDS. And it's more than just a disease story, isn't it? It's about human resilience working together.
And fighting that stigma, too. That's a huge part of it.
Definitely. So our mission here is to give you a really solid grip on the whole picture, the epidemiology, prevention, control.
Right.
We're using the latest global numbers from UNAIDS and WHO.
Hmm.
And then, this is cool, we'll zoom right in on Malaysia as a specific case study, see how it all works on the ground.
And I think you're really getting into the details about the successes, the challenges that are still there, the specific strategies that can genuinely shift how you see it all.
How so?
Well, it goes beyond just like abstract numbers. You start to see the incredible public health effort involved. And honestly, it gives you real insights into tackling these massive global health problems.
Okay, let's do it. So the big picture first. What are the current global estimates telling us? Where do we stand with HIV/AIDS right now?
Okay, so the 2023 figures from UNAIDS and WHO, they show nearly 40 million people, 39.9 million to be exact, living with HIV globally.
Wow, nearly 40 million.
Yeah, and in that year, there were 1.3 million new infections and sadly, 630,000 deaths from AIDS-related illnesses.
Gosh.
And another point, the gender split. 53% of people living with HIV are women and girls.
Over half.
Hmm. So the scale is still immense. But, and this is important, there's also real hope in these numbers when you look at the trends over time.
Okay, so it's not all grim news then. You mentioned shifts, progress.
No, definitely not all grim. The progress is actually quite remarkable. Since 2010, AIDS-related deaths have dropped by 57% among women and girls.
57%.
Yeah, and 47% among men and boys. Plus, new infections overall are down 40% since 2010, and deaths linked to HIV are down 51%.
That's huge progress.
It really is. And if you look at the global prevalence, like the percentage of adults aged 15-49 with HIV, that's actually sort of leveled off since around 2001.
Okay.
So it shows these global efforts are working. We're moving towards that UN target of getting under 350,000 new infections by 2030.
Right.
And the whole AIDS response has helped push forward like 10 of the Sustainable Development Goals, things related to health, equality, human rights.
So it has wider impacts too.
Exactly. But, it's not uniform progress everywhere. Some places, like Eastern and Southern Africa, have seen prevalence drop almost 5%. Great news.
Yeah.
But other regions, say Asia and the Pacific or Western and Central Africa, the decline is much slower, more gradual. So the fight isn't over, not by a long shot.
Right. Context is everything. So beyond these big numbers, who is actually most affected? You hear about key populations and vulnerable populations. Let's unpack that.
Yeah, this is where it gets really crucial for understanding the dynamics. The risk isn't spread evenly at all. For these key populations, the risk compared to the general adult population is, well, it's stark.
Oh, stark.
Okay, so men who have sex with men, MSM, they're 23 times more likely to acquire HIV. Sex workers, 9 times higher. Transgender people, 20 times higher.
20 times.
People who inject drugs, 14 times higher. Prisoners, 7 times higher. I mean, globally, the median adult prevalence is 0.8%.
Yeah.
But for transgender people, it's 9.2%. For gay men and other MSM, 7.7%.
So the averages hide these huge disparities.
Completely. It forces you to think about, the social factors, the inequalities, the vulnerabilities that drive this. And beyond those key populations, there are other vulnerable populations.
No.
Young people, for instance. Those aged 15 to 24 make up a third of all new infections.
A third. Wow.
Yeah. And women and girls remain deeply impacted. HIV is a leading cause of death for women of reproductive age. They often face, gender inequality, violence, plus biological factors that increase susceptibility. And we also need to think about groups like migrants or specific ethnic minorities who might face extra barriers, language, legal status, discrimination, getting the care they need.
It's so deeply tangled with social issues. And another layer is how HIV connects with other health problems, right? Like tuberculosis.
Absolutely critical link. TB is actually the leading cause of death for people living with HIV globally.
The leading cause.
Yes.
Yeah.
And HIV, tragically, fueled a resurgence of TB, especially in Africa. Someone living with HIV is 18 times more likely to develop active TB disease.
18 times.
Yeah. Now, there has been success. Joint HIV-TB services have helped reduce TB deaths in people with HIV between 2000 and 2020. There's still a gap.
What kind of gap?
Only about half the people living with HIV who need it are actually getting both the TB preventive treatment and their HIV antiretroviral therapy. So integrated care, still a challenge.
Okay, so that maps out the global situation, the challenges, the connections. Let's shift now to what we're actually doing about it. What are the main prevention strategies being used globally?
Well, UNAIDS pushes what they call a combination prevention approach, basically using lots of different tools at once because no single thing works for everyone.
Makes sense. Like what kind of tools?
So there's health education, helping people understand risks, behavior change, like promoting correct and consistent condom use, big one.
Right.
Then there's preventing mother-to-child transmission, huge success story there. We can talk more about that. Harm reduction for people who inject drugs, things like clean needle programs, opiate substitution therapy like methadone.
Harm reduction. Okay.
Yep. Voluntary male medical circumcision has shown benefits in some settings. And then there are the biomedical approaches. Using HIV treatment itself as prevention, getting the viral load undetectable, basically stops transmission.
Treatment as prevention.
Exactly. And pre-exposure prophylaxis. That's where HIV-negative people at high risk take ARV pills to prevent getting infected in the first place.
Quite an arsenal, then. How do we know if it's all working? How do we track this epidemic? What does surveillance actually involve here?
Good question. Surveillance is our eyes on the epidemic. It falls into two main types. There's biological surveillance, so testing actual samples. Think sentinel surveillance in specific groups, or screening blood donations.
Okay, testing blood and stuff.
Right. And then there's behavioral surveillance. That usually means doing repeat surveys to ask people about their behaviors, their risks.
Asking questions.
Exactly. But what's really powerful now is what we call integrated biological and behavioral surveillance, or IBBS.
IBS.
Yeah, sometimes called second-generation surveillance. Combines both the biological testing and the behavioral surveys, often focusing specifically on those key populations we talked about.
Why the focus?
Because you get much richer, more detailed data. You understand the links between behavior and infection within those groups who are most at risk. And that helps target interventions much more effectively.
And how do you even reach these groups? Some must be hard to find.
They can be. So specialized sampling methods are used, like time-location sampling, TLS, where you go to places and times where specific groups gather, or respondent-driven sampling, RDS. That's kind of like a snowball technique. You find a few people, they recruit their peers, those peers recruit others, often using small incentives. It helps map social networks and reach hidden populations.
Clever. Okay, tracking makes sense.
Oh.
Treatment, antiretroviral drugs, ARVs, what's their basic role?
ARVs have been, well, revolutionary. Simple as that. They improve health, they massively prolong life, and crucially, they dramatically cut the risk of transmitting the virus.
But they don't cure HIV, right?
Correct. No cure yet. But they turn HIV from what was often a death sentence into a manageable chronic condition. The main goal is to get the amount of virus in the blood, the viral load, down to undetectable levels.
Undetectable. Why is that the goal?
Because when someone's viral load is undetectable, the science is clear. They effectively cannot transmit HIV through sex. It nearly eliminates the risk is the official term. Undetectable equals untransmittable, or U.
Got it.
So starting ARVs soon after diagnosis is key. The big shift came with HAART, highly active antiretroviral therapy, back in 1996.
HAART. What was so special about that?
It used combinations of at least 3 different ARV drugs. And that combination therapy was powerful enough to really suppress the virus long term. It transformed everything. People could live for decades longer, avoiding those opportunistic infections that used to be so devastating.
Right. And you mentioned pre-P before for prevention. What about PEEP?
Yes. PP is post-exposure prophylaxis. That's taking ARVs after potential exposure, maybe a needle stick injury for a healthcare worker, or after a sexual assault. Pre-P is pre-exposure for ongoing risk. PP is for after a specific event.
Okay, clear distinction. So ARVs are central. How does testing fit into this whole picture?
Testing is absolutely fundamental. It's the gateway to both prevention and treatment. The CDC actually recommends everyone aged 13 to 64 get tested at least once, just routinely, and more often if you have ongoing risk.
Routine testing, what kinds of tests are there?
There are basically 3 main types. Nucleic acid tests, or NATs, can detect the virus itself very early on. Antigen antibody tests look for both bits of the virus, the antigen, and your body's response, the antibodies. And then antibody tests, which just look for the antibodies. Most rapid tests and self-tests fall into this category.
Self-testing, you can do it at home.
Yes, that's been a big development. HIV self-testing lets people collect their own sample, usually saliva or a finger prick blood drop, do the test, and get a result in about 20 minutes, all privately.
That must help overcome barriers like stigma or access.
Exactly. But it's really important to stress. A single rapid test result, especially a positive one from a self-test, needs confirmation with further testing in a clinic. It's not a final diagnosis on its own.
Got it. Confirmation is key. And all this testing and treatment, it feeds into those global targets you mentioned?
Precisely. The UNAIDS 95 targets for 2023. The goal was 95% of people with HIV know their status, 95% of those diagnosed are on treatment, and 95% of those on treatment have an undetectable viral load.
And how are we doing globally?
As of 2023, we were at 86% knowing their status, so a gap there. Of those, 77% were accessing treatment, another gap. And of those on treatment, 72% were virally suppressed. So progress, yes, but still work to do to reach 95 across the board. And the targets vary slightly for children, women, and men, showing where we need to focus more.
Okay. Let's dive a bit deeper into specific prevention strategies now. Sexual transmission, what are the main approaches there?
It really is that combination approach again. So delaying when young people first have sex, abstinence is an option for some.
Right.
Being faithful to one uninfected partner, if both partners are consistently faithful, reducing the number of sexual partners overall, and then critically correct and consistent condom use.
Condoms seem key. You hear about ABC and CNN approaches.
Yeah, those are mnemonics used in prevention messaging. ABC is abstinence, be faithful, condom use. CNN stands for condom use, clean needles, and negotiating skills, emphasizing the ability to insist on safer practices. And the male latex condom, despite all the advances, is still called the single most efficient available technology to reduce sexual transmission of HIV and other STIs.
Still the most efficient. Any examples where condoms made a huge difference?
Thailand's 100% condom use policy in the 1990s is a classic example. They really pushed for condom use, especially in sex work settings, destigmatized it, made them available, and it dramatically cut infection rates, really helped turn their epidemic around.
Wow. Okay, so that's sexual transmission. What about people who inject drugs and keeping the blood supply safe?
For people who inject drugs, the focus is harm reduction. Strategies aimed at minimizing the risks associated with drug use, rather than just focusing on stopping use altogether, though that's also a goal.
So practical steps.
Exactly. Needle exchange programs, NEPs, are vital, providing sterile needles, safely disposing of used ones. Often these programs also offer other services like testing or links to rehab. And opiate substitution therapy, OST, like methadone maintenance therapy, MMT. Giving a prescribed alternative like methadone helps stabilize people, reduces the need to inject illicit drugs, and lowers HIV risk behavior.
Right. And the blood supply.
That's about rigorous screening. Testing all donated blood for HIV, heat-treating blood products where possible, having criteria for who can donate based on risk, but being careful not to stigmatize, and just generally reducing unnecessary blood transfusions.
Seems straightforward, but is it universal?
Unfortunately, no. Many resource-poor countries still struggle to implement really rigorous screening for all blood donations. That remains a vulnerability.
And you mentioned VCT earlier, voluntary counseling and testing.
Yes, VCT is a really important entry point into care. It's confidential. It involves pre-test counseling, understanding your risks, what the test means, then the test itself with informed consent, and then post-test counseling, getting the result, understanding it, and crucially planning next steps, whether that's prevention or linking to treatment and support.
So it's more than just the test.
Much more. It's about support and connection.
Now, one area you highlighted as a huge success is preventing mother-to-child transmission, PMTCT. Tell us more about that.
Oh, it's genuinely one of the biggest public health triumphs in the HIV story. It's a four-pronged strategy.
4 prongs.
Yep. First, prevent HIV infection in women of reproductive age in the first place. Second, prevent unintended pregnancies among women who are living with HIV. Third, prevent transmission from mother to baby during pregnancy, labor, delivery, or breastfeeding, primarily using ARV treatment for the mother and sometimes the baby, plus safe delivery practices and infant feeding counseling.
Okay, that's 3.
And fourth, provide care, treatment, and support for the mothers, their children, and their families living with or affected by HIV. It's holistic.
And the results.
Incredible.
Yeah.
By the end of 2020, 14 countries, including places like Malaysia, Thailand, Maldives, Sri Lanka, had actually been validated by WHO for eliminating mother-to-child transmission of HIV and/or syphilis as a public health problem. The goal is literally 0 new infections in infants.
Yeah.
And they're showing it's achievable.
That's amazing. Real hope there. But despite all this progress, there are still major global challenges, right? Where are we still falling short?
Definitely. Progress on prevention has stalled in some places, especially among certain groups like MSM, where infections are actually rising in some regions. We absolutely have to tackle the social and legal barriers, stigma, discrimination, laws that criminalize key populations that stop people from getting the services they need.
The social barriers again.
They're huge. And on testing, it's still a major concern that over 40% of people living with HIV globally don't know they have it. We need testing to be way more accessible, affordable, and routine.
40% is a lot of people unaware.
It is. And finally, there's the issue of money. Sustainable financing for the AIDS response is a constant challenge, especially as some middle-income countries transition away from international donor funding.
Okay, that gives us a really solid grounding in the global picture. Now let's bring it home, like you said. Malaysia, what does the HIV epidemic look like there? What are the specific trends?
Malaysia's a really interesting example. First off, they've seen a really significant drop in their overall rate of new infections. It went from 28 per 100,000 people back in 2002, down to 9.7 in 2023.
That's a big decrease.
It is. And new infections have been pretty stable since about 2008. Malaysia is considered a middle-income country with what we call concentrated epidemics, meaning HIV is mainly concentrated in specific key populations, and the prevalence in the general population is less than 1%.
Okay. And how is it transmitted there? Is it different from the global picture?
There are some specific patterns. In 2023, looking at males, about 24% of new infections were linked to injecting drug use, but almost 75% were through sexual transmission. And that's increasingly among men who have sex with men, MSM.
So a shift towards sexual transmission among men.
Yes. And for women, it's overwhelmingly heterosexual transmission, over 92% in 2023. Interestingly, while men still account for more infections, the proportion of infections among women has been slowly increasing. The male-to-female ratio has declined over the years.
Suggesting heterosexual transmission needs more focus, too.
Exactly. It highlights the changing dynamics within the country.
So given that specific picture, what's Malaysia's strategy? How are they aiming to tackle this?
They have a National Strategic Plan for Ending AIDS, the NSPA, running from 2016 to 2030. It directly adopts the UNAIDS Ending AIDS vision, the 3 zeros. 0 new infections, 0 discrimination, 0 AIDS deaths.
Ambitious.
Very. The plan aimed to hit those 90 targets by 2020 and is now pushing for 95 by 2030. And the core of their strategy, testing and treatment, really scaling those up alongside targeted prevention.
What are the key priorities within that plan?
Well, intensifying testing and treatment is number one. Then really boosting harm reduction programs, the needle exchange, methadone therapy, reducing sexual transmission with specific focus on key populations and also that successful PMPCT program, and crucially, tackling stigma and discrimination, which they recognize as major barriers.
Sounds comprehensive. Can you give us some highlights, specific programs where Malaysia has really excelled or innovated?
Yeah, they've done some impressive things. Their HIV screening is pretty extensive. They have universal opt-out screening in many healthcare settings, plus routine screening for pregnant women, prisoners, TB patients, people getting blood transfusions.
Opt-out screening.
Meaning you're tested as part of routine care unless you specifically decline.
Mm-hmm.
They also do mandatory testing for blood donors and migrant workers.
Okay.
And we already mentioned their PMTCT success, eliminating mother-to-child transmission. They started that program way back in 97, 98. Really ahead of the curve.
Wow, early adopters.
Yeah, definitely. Another unique thing is their premarital HIV screening. It started as a pilot for Muslim couples in one state back in 2001, but now it's available pretty much nationwide for people of all faiths. It combines the medical screening with counseling, sometimes involving religious perspectives too.
Interesting approach. What about treatment access?
The Ministry of Health provides first-line ARVs for free. Second-line drugs are subsidized, so access to the basic life-saving meds is pretty good. They also have PEP available for healthcare workers exposed on the job, and they're rolling out pre-EP for key populations.
Okay, you mentioned harm reduction and pre-EP. Let's dig into those a bit more. How significant have harm reduction programs been?
Hugely significant, especially given Malaysia's history with injecting drug use driving the epidemic early on. Their needle and syringe exchange program, NSE, and the opiate substitution therapy, OST, like methadone. Modeling suggests these programs alone could reduce new HIV infections by almost 80% between 2006 and 2050.
80%, that's massive impact.
It really is. And they're innovating, too, with things like the Differentiated HIV Services for Key Populations program, DHSKP.
DHSKP, what's different about that?
It's about tailoring services. It's a national program run in partnership with NGOs. It integrates case management support from NGOs with the actual treatment provided at government clinics. It makes care much more user-friendly and less stigmatizing for key populations who might not easily access standard clinic services.
Meeting people where they are.
Exactly. And now, the really cutting-edge stuff, that pre-IP pilot program for MSM, started in 2023 in 18 clinics.
Why is that so important for Malaysia?
Because, as we said, MSM are projected to be the main key population driving new infections there by 2030. So targeted, effective prevention like PEP is absolutely vital.
And are the results yet? It's quite new.
Early results, yes, and they look really promising. As of late 2023, they had about 3,500 clients enrolled, and among those followed for a year, they saw a significant drop in new syphilis infections from 11% down to 1.3%.
Wow, that's a big drop in STIs, too.
Yeah, indicating safer practices. Condom use also increased, from 30% reporting consistent use at the start to 44% after a year, and more clients reported having only one sexual partner that went from about 7% up to nearly 30%.
So positive behavior changes alongside the PEP itself.
Absolutely. And interestingly, 51 clients actually stopped PBP because they felt they were no longer engaging in high-risk activities, which suggests the program supports broader risk reduction, too.
That's fascinating. Did they face any hurdles rolling out PPP?
Well, they were proactive. They engaged with Islamic affairs authorities early on to explain PEP and build understanding and support, which was smart.
Good strategy. And self-testing, is that available?
Yes. Launched in December 2023. They have a dedicated website, testnow.com.my, and it's linked through the National Mysejahtera Health app. They emphasize the 5 C's: consent, confidentiality, counseling, correct results, and importantly, connection to care, making it private, accessible, but also ensuring people get linked to support if needed.
Sounds like a lot of innovative service delivery, but what about the basics, general awareness, and that persistent issue of stigma? How's Malaysia doing there?
That's definitely still a challenge. They've had awareness campaigns over the years, like one back in '92 themed AIDS is a Killer. NGOs like the Malaysian AIDS Council, Empatha, have been vital players. And there's a long-running youth program called ProStar, started in '96, that trains young peer educators. That's been quite successful in reaching young people.
Peer education, yeah.
But a survey in 2023 delivered some sobering news. Only 11% of young Malaysians, aged 15-24, actually had a correct understanding of how HIV is prevented and could identify common myths.
Only 11%. That's really low.
It is. It shows a big gap in basic knowledge, despite the programs. And stigma.
Yeah.
Yeah, it's a major issue. A 2021 survey found over 70% of people living with HIV in Malaysia reported feeling shame because of their status.
70% feeling shame. That's heartbreaking. And such a barrier.
A massive barrier. It stops people testing, stops them disclosing, stops them getting support. It really undermines everything else.
Definitely something that needs more than just medical solutions. How are all these efforts funded? Is there international support? How does the collaboration work?
International funding has been important. Malaysia has been eligible for grants from the Global Fund for AIDS, TB, and Malaria, GFATM, since 2008 because of its status as a middle-income country with concentrated epidemics.
The Global Fund, right?
And they have a country coordinating mechanism, or CCM. It's a multi-sectoral body, government, NGOs, community groups all involved that oversees how those Global Fund grants are used. The Malaysian AIDS Council actually acts as the principal recipient, managing the funds.
So collaboration is built into the structure.
Very much so. That multi-sectoral approach is key for making sure the response is comprehensive and reaches everyone who needs it.
Okay. So, wrapping this all up for our listener, we've gone from the global scale of HIV, the huge numbers, the incredible progress in treatment and prevention like PMTCT, but also the persistent challenges like stigma and reaching key populations. All the way down to a specific country, Malaysia, seeing how they're applying these strategies, innovating with things like pre-EP and differentiated care, but still battling awareness gaps and stigma.
And I think seeing both levels, the global trends and the specific on-the-ground reality in a place like Malaysia, it really underscores the complexity of public health.
Yeah.
It shows how much targeted interventions matter, how vital education and treatment access are, but also how powerful collaboration across government, NGOs, communities truly is. It's science, yes, but it's also about people working together.
Absolutely. So we leave you with this thought. If the ultimate goal really is those 3 zeros, 0 new infections, 0 discrimination, 0 AIDS deaths, what do you think is the single most critical breakthrough humanity still needs? Something maybe beyond the purely medical. What's the next big leap we have to make?
Yeah.